Good morning, everyone. I have got the Placenta Previa and the Placenta accreta guideline summarized for you to help with your revision of MRCOG exams. Please don't forget to give this video a thumbs up and subscribe to my channel if you haven't already, so you can keep yourself updated with lots of more of content that I'm going to upload to help with your MRCOG revision. So placenta previa is placenta when placenta lies directly over the internal os. Over 16 weeks of gestation, the term low-lying placenta refers to when the placental edge is less than 20 millimeters from the internal os on a transabdominal or transvaginal scan. Placental location scan is routinely done in mid-pregnancy between 18+6 and 21+6 weeks. Placenta previa, the incidence is at term is 1 in 200 pregnancies. Risk factors are your previous cesarean section. So the risk increases as the number of previous cesarean section also increases. Your assisted reproduction techniques, so things like your IVF and maternal smoking. So low-lying placenta that's less than 20 millimeters from the internal os or Previa covering the os at routine anomaly scan. Then you do need another follow-up scan, including a transvaginal scan at 32 weeks of gestation to diagnose persistent low-lying placenta and or placenta previa. Placental migration in third trimester results in resolution of low-lying placenta in 90% of cases before term. After 32 weeks, 50% of the remaining placenta previa will resolve. No further changes after 36 weeks. Ultrasound in third trimester between 32 and 36 weeks, depending on extent of placenta previa over the internal os. It's based on the perceived risk of antenatal hemorrhage, but there's no strong evidence that it makes a difference in the care of asymptomatic women. So really, depending on your local trust guidelines, some trust would recommend doing it at 32, 34, 36, but the guidelines say anywhere between 32 and 36 is fine. Transvaginal scan for diagnosis of placenta previa or low-lying placenta is superior to transabdominal and transperineal scans and is also safe. Persistent low-lying placenta or previa at 32 weeks, and if the patient is asymptomatic, then additional scans should be done around 36 weeks to inform discussion about mode of delivery. Cervical length measurement in asymptomatic women with placenta previa, a short cervical length on TV scan less than 34 weeks increases risk of preterm emergency delivery and massive hemorrhage at cesarean section. If distance between internal os and the placental edge is 20 millimeters or more on transvaginal scan, then the placental location is treated as normal and routine care should be offered. So asymptomatic placenta previa or low-lying placentas in third trimester should be counseled about risks of preterm delivery and obstetric hemorrhage. Asymptomatic placenta previa confirmed at 32 weeks. Follow-up scan should be, a 32-week follow-up scan. Then they should have all the safety precautions informed to them. So, things like having somebody to bring them to hospital, having all the contact details of the local unit if they needed to come in an emergency, if they were bleeding, and what to look out for in terms of if they started to bleed, when to ask for help. Single course of steroids should be given between 34 and 35+6 for pregnant women with low-lying placenta or placenta previa, and is appropriate prior to 34 weeks at those who are higher risk of preterm birth. Tocolysis for women presenting with symptomatic placenta previa or a low-lying placenta may be considered for about 48 hours just to allow administration of steroids. If delivery is indicated for maternal or fetal reasons, tocolysis should not be used in attempt to prolong gestation. Late preterm, so between 34 to 36+6 weeks, should be considered for women presenting with previa or low-lying placenta and a history of vaginal bleeding or risk factors for preterm delivery. Delivery timing tailored according to antenatal symptoms and presenting with uncomplicated placenta previa. Consider delivery between 36 and 37 weeks. Discussion regarding delivery, indications for blood transfusion and hysterectomy, and plans to decline blood or blood products should all be discussed and documented clearly in the notes. Placenta previa and anterior low-lying placenta carry a higher risk of massive obstetric hemorrhage and hysterectomy. Delivery should be arranged in a maternity unit with on-site blood transfusion services and access to critical care. Atypical antibodies from a form a particularly high risk group, and discussions with local hematologists and blood banks should all be done so that blood can be arranged and blood products can be arranged in time for the delivery. Prevention and treatment of anemia during antenatal period is recommended for women with placenta previa or low-lying placenta, as for any other pregnant women. Risk of massive hemorrhage together with possibility of blood transfusion is 12 times more likely in caesarean section for placenta previa than for caesarean section for other indications. Cell salvage is recommended when the anticipated blood loss will induce anemia, especially when the patient is declining blood products. Consider a vertical skin and/or uterine incision if the fetus is in transverse lie to avoid the placenta, and especially less than 28 weeks. Pre-op and intra-op ultrasound can be used to determine placental location and optimal place for uterine incision. If placenta is transected during uterine incision, immediately clamp the umbilical cord after fetal delivery to avoid excessive fetal blood loss. If pharmacological measures fail to control hemorrhage, initiate intrauterine tamponade, so your Bakri balloon, for example, and/or surgical hemostatic techniques sooner than later. Interventional radiological techniques should also be urgently employed where possible. Early recourse to hysterectomy is recommended if conservative medical and surgical interventions have all proven to be ineffective. Placenta accreta, so that is between 1 in 300 and 1 in 2,000 pregnancies. Depth of the villus tissue invasiveness defines what sort of placenta accreta is it. So placenta accreta is further divided into creta or adherenta, where the villi adhere superficially to the myometrium without interposing decidua. In creta, villi penetrate deeply into uterine myometrium down to the serosa, and percreta is where the villus tissue perforates through entire uterine wall and invades surrounding pelvic organs like the bladder. So risk factors for placenta accreta is history of accreta in a previous pregnancy, previous caesarean delivery, and other uterine surgery, including repeated endometrial curettage, maternal age, and assisted reproductive technique. Risk rises as the number of previous caesarean section increases. Incidence of accreta placentation is 3.3 to 4% in women with placenta previa and no caesarean section. It increases to 50 to 67% in women with 3 or more caesarean deliveries. Placenta previa and prior caesarean section, the risk of accreta placentation is 3% in somebody with 1 previous section, 11% in somebody with 2 previous section, 40% in somebody with 3 previous section, 61% in somebody with 4 previous section, and 67% for somebody with 5 or more caesarean section. So that's having accreta with presence of previa in somebody with previous caesarean sections. Those are the percentages. Quite important to know for your MRCOG Part 2 exams. MDT in maternity units with access to maternal and neonatal intensive care is often required for women with placenta accreta. Ultrasound is highly accurate when performed by a skilled operator. Refer women with any ultrasound feature suggestive of accreta to a specialist unit with imaging expertise. Clinicians should be aware that the diagnostic value of MRI and ultrasound in diagnostic accreta is similar when performed by experts. MRI may be used to complement ultrasound imaging to assess the depth of invasion and lateral extension of the myometrial invasion, especially with posterior placentation and or in women with ultrasound signs suggesting parametrial invasion. Absence of risk factors for preterm delivery with placenta accreta, planned delivery at 35 to 36 plus 6 weeks, best balanced between fetal maturity and risk of unscheduled delivery. Suspected placenta accreta, significant blood loss, and caesarean hysterectomy should be anticipated. Delivery between 34 and 35 weeks to avoid emergency delivery, which can happen 20% of the time. 6 elements of reflective of good care. So consultant obstetrician planning and directly supervising delivery, consultant anaesthetist planning and directly supervising anesthesia at delivery, blood and blood products available, MDT involvement in pre-op planning, discussion and consent, hysterectomy, leaving placenta in, cell salvage and intervention radiology. So all these discussions and planning should have happened. Local availability of at least level 2 critical care bed. So, caesarean section hysterectomy with placenta left in situ is preferable to attempting to separate it from the uterine wall. When the extent of the placenta accreta is limited in depth and surface area, and the entire placental implantation area is accessible and visualized, uterus preserving surgery may be appropriate, including partial myometrial resection. Uterus preserving surgical techniques should only be attempted by surgeons working in teams with appropriate expertise to manage such cases and after appropriate counseling regarding the risks and with informed consent. Use of stents when the urinary bladder is invaded by placental tissue can be done it doesn't really avoid injury, but it can help with the surgery. Limited evidence to support uterus preserving surgery in placenta accreta, and women should be informed that there is high risk of peripartum and secondary complications, including the need for secondary hysterectomy. So primary hysterectomy, there's 4 options that we can do with the placenta in case of accreta. So primary hysterectomy after delivery of fetus without attempting placental separation, delivery of the fetus, avoiding the placenta with repair of the incision, leaving the placenta in situ, delivery of the fetus without disturbing the placenta, followed by partial excision of the uterine wall and repair of the uterus, delivery of the fetus without disturbing the placenta and leaving it in situ, followed by elective secondary hysterectomy 3 to 7 days after following the primary procedure. Elective peripartum hysterectomy, so desiring if a patient is desiring uterine preservation or it's inappropriate or surgery is considered inappropriate by the surgical team, then leaving the placenta inside should be considered. If the placenta is left in situ, local arrangements should be made for regular review, ultrasounds and access to emergency care in cases of bleeding or infection. Methotrexate should not be used for expectant management as its unproven benefit and has significant adverse effects. Placenta accreta, if the patient declines donor blood transfusion, then it should only be carried out in units where there is interventional radiology service. At elective repeat caesarean section, if both the mother and the baby are stable and there's apparent placenta accreta, then on opening the abdomen, then caesarean section should be delayed until appropriate staff and resources available, adequate blood products are available. Sometimes you even have to close the maternal abdomen and arrange for urgent transfer to specialist unit for delivery. Unsuspected placenta accreta spectrum after birth of baby, placenta should be left in situ and emergency hysterectomy should be performed. It's important to debrief the patient after what you've done in the procedure because there's usually excessive blood loss, sometimes bladder injury, bowel injury, ureteric injury, and complications like these can happen. So it's important to inform the patient about what's happened and who was involved. Adequate training should be provided to staff to manage cases of excessive bleeding, so massive obstetric hemorrhage, and also what to do in cases of placenta previa and accreta. And an incident report should be filled out so the documentation, the notes, and everything can be reviewed. So if there are any lessons to learn from this, then that can be done. So this is just a flow diagram that kind of like explains everything that I've gone into detail, but it just in like a simpler format. I'll leave that on for a few seconds for you to go through. This is just some of the terminology that they've used in the ultrasound imaging signs commonly used to diagnose placenta creta, and how it's all described. Again, you can read this in your own time. Well, that's it. That's the entire guideline summarized for you with all the important salient points for revision of your MRCOG exams. I hope this video is going to be very useful for you, and if it is, then show that with hitting that thumbs up button and subscribe to the channel and share it with your friends and colleagues so they can all benefit from this learning. Also comment and let me know what you found the most useful in this video, and also if you'd like to see me summarize any other guidelines or any other TOG articles that you are struggling with and you'd like some help on. Good luck revising.